Thank you very much for this question. Actually, NGS or gene mutations are something very important nowadays in understanding the MDS disease and to manage the patients. Hopefully, this technique will be disseminated worldwide, because right now, as I said during the conference, IPSS-R is still a valid scoring system, but IPSS-M that integrates gene mutation, it's maybe a better system, because now we can break down the population into 6 categories, but we're still having lower risk, higher risk, and intermediate. So for me, it's something important at the beginning, because some patient we can reclassify them and we can decide for the treatment, transplantation or not, for instance. And then even after transplantation, you can follow up those patients with these mutations. We don't have right now a real measurable residual disease, I would say, for MDS, but NGS after transplantation can help for this matter. In a few cases, we can use some targeting molecule, because now we have inhibitor for IDH2, for instance. TP53, no, we don't have enough things, but why not in the future? Maybe we can personalize the treatment for MDS. Right now, I would say NGS help us better classify the patient and better decide for the treatment, and maybe follow them up after transplantation. Yes, of course. So in patient aged at least 70 years old and with no comorbidities, with higher risk MDS, we go to upfront transplantation, I would say. We're still hesitating for patient with intermediate risk or some patient with low risk or lower risk, So I think having or harboring these gene mutations, as you said, sometimes we switch to upfront transplantation on those patients instead of waiting, the increase of number of blasts, etc., because we can foresee rapid progression of the disease. So we need to think about transplantation on those patients. Okay, thank you. So this is a very important question. I don't have a clear answer for this, because we haven't done that much progress right now. However, I can tell you, for patients with lower risk MDS, now we can manage those patients better than in the past, and we can really give them treatment to reduce transfusion dependency, for instance, how to manage iron overload on those patients. For patients with higher risk, outside transplantation, I really encourage our colleagues to include those patients within clinical trials whenever possible, because really we need to explore all these new drugs coming up, to see if really we can change the prognosis of this disease.